Welcome to the OrthoPAC podcast with your hosts Sam Dyer, Chuck Dowell, and Miles Gilbreth. Please join us as we attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, Dr. Bert, where we continue our discussion of hip arthroscopy and associated pathologies. Dr. Bert, I have a couple of questions for you. The last time we had our interview, you had talked about CAM lesions being treated arthroscopically and some new technology to make sure you had done enough.
So for CAM resection, the technology evolved over the last, 5 to 10 years. We've really learned that CAM resection is the key to avoiding a revision surgery. We think that unresected CAM is responsible for up to 80% of revision cases. So you really want to be very precise and have an adequate CAM resection before the patient leaves the OR. What I've been using is a software program that is connected with the fluoroscopy. And so when you're performing the CAM resection, we do 6 different views on the hip, with the hip in neutral, a little bit external rotation, a little more external rotation, and then we put into full extension and do the same angles. What this technology does is the software program that overlays a ideal line for the resection on your fluoroscopy. So you can look at it in real time, take an x-ray and say, all right, this is where my CAM lesion is. This is where the abnormal bone is. This is how much we're going to resect. And it's called hip check. And so it actually has these lines that shows you where to resect it. And then it goes from orange to green when you resect enough. So that's a big part of ensuring that you've adequately resected enough bone. The other thing that we do now, which is more common, is we do dynamic exam. So we use postless distraction, meaning when we pull on the patient's hip to distract it, we don't put a post between the legs, we just use a memory foam. And then that gives us the ability to put that hip into that fader position intraoperatively. So I like to check on everybody after we resect that bone to see if they're still impinging on the labrum. So I'll put that patient into fader while they're asleep, and I ensure there's clearance. And so if you confirm there's clearance intraoperatively, it's very unlikely they're going to have residual impingement symptoms after surgery if they rehab correctly and get their core and glute strong and get their posterior pelvic tilt reestablished. So those are probably the 2 biggest I think technological advances. There is some research right now working on, I believe, some sort of robotic resection, which I think will be in the coming, hopefully next 3 to 5 years. They'll be able to figure that out to allow a more precise resection with the assistance of robotics.
I was hoping you might give our listeners a little bit of the post-op course when someone's had a hip arthroscopy, say for the labral repair or whatever. What's their typical course? Physical therapy? When can they get back to sports and those kinds of questions?
Yeah, so what I'll typically do is I will have the patient be 20 pounds weight bearing for 2 weeks, and that allows them to put some weight on it, because if they do non-weight bearing, what happens is their hip flexor gets sore from being in a flex position all day. So we do 2 weeks, 20 pounds weight bearing. After 2 weeks, they start weight bearing as tolerated. Typically, that means they're on crutches for up to 3 to 4 weeks based on how they're progressing getting off the crutches. We like to make sure they do not have a gait abnormality when they get off crutches. The first phase, which is the first 2 weeks, we do try to protect all the repaired tissue. We have restrictions in range of motion, and we really want to diminish pain and inflammation. The second phase is week 3 to 8. What we're still doing is protecting the repaired tissue, but we're trying to reestablish full hip range of motion before we start strengthening. We want to normalize the gait pattern from week 3 to 8. And so sometimes we go down to 1 crutch until that gait is normal. You're not limping anymore. And then we're emphasizing glute strengthening, non-weight bearing. Phase 3 is advancing from weeks 9 to 12. That's when we're trying to restore full muscular strength. And then at week 12, what we'll typically do is work on endurance. So that's straight line treadmill running is the earliest we start is week 12. Month 4, what we'll do is some plyometrics. So that's quicker movements from side to side in clinic. So if they're pain-free with plyometrics, then typically by month 5, I'm letting them play sports. So return to sports typically month 5, as long as they've progressed without pain, their motion is reestablished, their strength is good, and they're able to play that specific sport without pain. So that's kind of the typical treatment timeline, I do tell patients it is a full year to feel 100%, but most people at that 6 month mark are feeling pretty good.
I have one follow-up question with that. What is the most common thing that you could think of that would result in a problem for patients after they've had this surgery? Is it the pathology or the severity of the problem or post-op compliance with rehab? What's been your experience with that?
I think it's rehab. I think a lot of patients, especially patients that are very, type A that want to get back quick, they'll sometimes cut corners or try to rehab too quickly, and then they'll get hip flexor tendonitis. And I think that's kind of the most finicky issue that patients and physical therapists will see in the rehab of the hip. So I think really focusing on strengthening the hip without irritating the hip flexor is the key to having a less painful recovery. So I think if you get through 3 months without having a hip flexor tendonitis, then that is probably the most painful, I think, issue that patients deal with is hip flexor tendonitis, especially as they get back to walking. If you do a good repair and you do everything perfectly, you can still have hip flexor tendonitis if you're moving too quickly or trying to walk long distances too quickly or trying to get back to a sport too quickly. So that's the one thing I caution all patients on is you got to listen to your body. You got to slowly progress. And if you do get hip flexor tendonitis, you got to back off, let the therapist treat you. That can be dry needling, that can be hip flexor stretching, and then build up strength again.
Awesome. Well, that's all the questions I have. Miles and Chuck, do you have any follow-ups for Dr. Burt?
Just a quick follow-up. So you were talking about cam deformities and pincer deformities, and just, I guess for us, for educational purposes, my understanding is the cam deformities are more common in males, right? Because of the physeal stress when they're young, and the pincer deformities are more common in females. But from your perspective, the cam is the one you're more concerned about, right? Because that causes the wear at the chondrolabral junction. That's the one that typically more progresses to osteoarthritis.
Correct. So they've been able to link cam deformities with progression of arthritis. And there was one good study by Dr. Brian Kelly. He looked at 10-year data, and he looked at the normal hip on the patient and then the operative hip. And they had him do 10-year follow-ups with x-rays. What he found was that about 25% of the patients that had the operative side fixed and the other side not fixed, the about 25% of the patients progressed on the non-operative side to worsening arthritis compared to the one that was operated on. And so he's been able to directly link cam deformity to progression of OA. Now, there's been no studies that confirms that if you have a pincer deformity, that your hip will progress to arthritis. So I think that's, a big part of it is, it's an outside in injury versus a crushing deformity of the labrum. So the crushing deformity of the labrum doesn't necessarily cause arthritis. It can cause pain, but doesn't necessarily lead to progressive arthritis. But the cam deformity can, because it does cause that shear stress across that chondral surface in the acetabulum.
So if we're seeing a patient in clinic and we're measuring the alpha angles or kind of seeing that offset and we see a cam deformity, are you typically a little bit more proactive in those patients as far as recommending surgery versus more conservative treatment because of that progression?
Exactly. Yes. If you have a large cam deformity, I'm going to be less optimistic that you're going to get better non-operatively. Every patient needs to do physical therapy regardless of the future treatment plan. You still need to do physical therapy, and insurance companies require that. But I will tell patients that are younger that have a large cam deformity that you should have this treated sooner than later, because if you decide to say, well, I'm going to put this off for a couple of years, your risk of having irreversible chondral damage to your acetabulum is higher if you have a large cam deformity.
Of the alpha angles and the center edge angles, are those the main two that you typically look at in clinic just from a screening perspective, or are there other things, Dr. Burt, that you look at?
Yeah, I mean, alpha angle is the big one for the cam deformity. You're going to look at lateral center edge angle. You're going to look at anterior center edge angle. Those are the big ones for pincer and cam. Correct.
Perfect. Thank you very much for your time.
Yeah, no problem.
Yeah, and I actually have a follow-up question on that. Has anyone ever tried to just correct the cam deformity as opposed to going into the labrum?
There is some physicians that have, without fixing the labrum, done some cam resection. I think The issue with that is that you do have an unstable labrum, and I believe it still has some motion when you're moving your hip. And so even if you don't fix the labrum, theoretically you're not impinging anymore. But I think even some slight movement can cause pain if you fail to repair the labrum. So I don't think the standard of care still is repair the labrum, do the cam resection. Now the trend I think is there's going to be less acetabular osteoplasties. I think there's less and less people doing that because I think pincer deformities, we're finding out you don't necessarily need to bring the center edge angle down to a certain degree, like 30 degrees from 40. I think if it's in the high 30s or even 40, you can do a cam resection and make sure there's no further impingement and they'll do fine. I don't think you necessarily need to bring them down to a certain degree. And I think we're moving away from that. The other thing is when you're doing an acetabular osteoplasty now, you're burying that bone, and that can be a source of adhesions. And that's another reason you may have to have revision surgery. So I think there's more physicians now doing less acetabular osteoplasties for that reason. And they're really focusing on the cam resection.
Thank you.
Yep.
Dr. Bert, we really appreciate you coming back on, taking some time out of your schedule to talk with us. And I also want to tell you thanks for coming to the Ortho in the West. We really appreciate it. Great talk, a lot of great questions, good feedback. So hope you'll keep coming back to visit us. And thank you so much for your time.
All right. Thank you. My pleasure.
Thank you for joining the OrthoPAC podcast. Please follow the Physician Assistants in Orthopedic Surgery on social media. Connect with us on Facebook, Instagram, LinkedIn, and Twitter. Please subscribe to our podcast. If this has been helpful, please take a moment to leave a review.